Slide over a little bit. In this position, as she goes to throw, I want to see if I can reproduce the symptoms. So push forward, nothing there. And then if I push back, now push forward. Is that okay? Mm-hmm. Okay, so I'm not pushing her out in that position. And then if I needed to, I would do a reverse and just push up and have her do the same thing. Push forward, and that's okay as well. And then the test I've been using for slaps, I do O'Brien's, and I do something that we're calling the passive distraction test, which I thought was incredibly accurate until I looked at my results. If you put somebody in 135 degrees of elevation and then pronate them, my feeling was, which is the position in which divers go into the water, which is how this whole thing started, they're pulling on their biceps attachment and they're symptomatic. It's about 65% accurate. But if that's negative, and the O'Brien's is negative, the negative predictive value is 90%. So if I do an O'Brien's and a passive distraction and they're both negative, I know I don't have a slap lesion. Now, from this, I would have her flip over on your left side, and usually I would have something to put under her head. And just relax it for a sec. Thank you. And just go real loose. You good? Perfect. Like a piece of cooked spaghetti. Okay. And she's got anterior laxity. I don't know, are you seeing that? She's out, she's back. And then I'll test anterior, posterior, inferior, she's out. And I didn't do her sulcus test because I was busy talking. I don't see any, there's a little bit of anterior superior. So she may have a positive sulcus sign. And then we'll see what's the effect of rotation. So externally rotate. She tightens up in the front. Just relax it. Perfect. Thank you. Doesn't change the back, though. And with internal rotation, no clicks or grinds, by the way. Internal rotation, that tightens up. Okay. And now let me get you sitting up, if you would. Face this way, so I don't have to, towards me if you would, so I don't have to, you're doing great. And, okay, and then her sulcus is in neutral, not so bad, a little bit, but she's an overhead athlete, so you'd expect a little. She's 17 years old, you expect a little, but it decreases in external rotation, so her interval is okay. So come face this way, if you would. So what I'm seeing is that there are some proximal kinetic chain problems, scapulothoracic problems. Her diagnosis is she's got functional posterior instability. She's living with it, she's coping. I don't expect that scapulothoracic rehab is going to do a whole lot. I mean, it'll make it better, and she's coping with it now, and I wouldn't necessarily be thinking aggressively. I'd want to see how does she do in response to therapy, and does it make it easier for her to cope, and is she willing to function around that before I'd be making any decisions about doing anything interventional. I know she's had an MR arthrogram, but I don't know the results.
They said it was fine. I had a little fluid in my shoulder, but that's it.
Okay, which is what you'd expect. I didn't feel any clicks or grinds as I was doing it. Okay, gentlemen. Show us your tricks.
I think that the tests are extremely interesting and completed. The only thing that I ask my patient, maybe not in this case, but usually, if they suffer from any metabolic disease, I expect that this is a very important question to ask to the patient because some dysfunction in the shoulder are correlated to metabolic disease, like capsulitis, for example, is much more frequent in diabetics. And I ask if in your family is someone suffering from, if you have daughter, if you have, your mother is suffering from the same problem, because sometimes maybe there is some genetic correlation with patholaxity. And I check, as you have done also, the other side, and I ask the patient if she is suffering from similar on the left shoulder. Okay.
The one thing that I didn't do is I didn't check her hyperlaxity. Good, and straighten your arm out. So she does have hyperextension of her elbow. And can you place your thumb against your wrist? Yeah. Okay. So she's congenitally lax, but her left shoulder is doing fine.
Thanks. Yeah, those are great points. I think the Gagey test is very important here because, as Gerber's talked about, it's essentially a hyperlaxity with at least a functional posterior instability component. So you're dealing with not just a pure traumatic posterior instability, you have a hyperlaxity issue to deal with as well, and I think the Gagey sheds a lot of light on that. What I think is interesting about this case is the quote-unquote voluntary aspect, that she can come out doing these activities, or almost like here, if you can maybe just, could you just come try to push your shoulder out of joint? She has, there it is. If you turn to the side, this is a wonderful example. If you turn to the side, this is a wonderful example of posterior inferior. You can see the click. But that's reduced. Do you mind doing it? That's plenty. I know it's not comfortable, but she has learned this position. No one taught her this position, but the arm is in flexion and internal rotation, and it's essentially able to push the shoulder out posterior inferiorly around the 7 o'clock position, and then is able to reduce it. And this is a different type of a different type of voluntary instability. It's positional instability, and she's learned this position. It's not necessarily a bad thing. You don't need to run away and order other consults or psychiatry or everything else like that. This is just what her shoulder has learned. So I think you knew this right away from the history, as Ben pointed out. You knew that she was coming out in backstroke. A few more of my questions have been, can you do this? Can you position, what position is your arm in when this comes out of joint? And you almost don't even, you know the diagnosis before you even start with the physical exam.
Okay. We have about 5 minutes, so do we want to do questions? Do you want, Matt has some cases that he's prepared. It's your session. Colleen, I think we're all set.
Thank you.
Thanks so much.
I think with this case, it's also interesting, and Ben hit on it, is which came first here? Is it the scapulothoracic dysfunction, or is it the posterior component and stretch? And posterior instability is a weird animal. It's not like anterior instability. It behaves very differently. The posterior capsule is very thin. It's not biomechanically strong. So if you lose those dynamic stabilizers posteriorly, it's easily incited to injury. So I think a good combination. Ben, would you offer her surgery?
I would want to see how she responds to physical therapy, because right now she's dealing with it, and her major complaints are when throwing in water polo and when swimming. And part of the history is how important are those activities to you, and if it's not happening with activities of daily living other than those, and those aren't important activities, then